Anyways, my name is Zach, PGY4. Hopefully everyone knows me or at least knows my face. My topic was more preparing for life after residency. I think we all get a lot of good training here. I would say like once you start reaching fourth year and then when you start trying to like venture out and look for jobs, you kind of feel like you're like out on your own, like venturing out, trying to, find jobs. And it's kind of scary for some people. So I just try to pick a lot of things, a lot of topics where I thought could be helpful. Like there's some things that we could do like more in depth, like a whole like lecture on. So I'm just gonna like quickly go through a few things. The outline is about to be like CV, cover letters, networking, finding employment. A big thing for me, like my job is like RVUs, so I wanted to touch bases on that, and then also like licensing and like miscellaneous costs. I know a lot of like the third years are in court, so most of you guys are like first and second years, but you guys can still learn from it anyways. In regards to the CV, um, even as an intern, you guys already have like your med school CV. I would recommend starting early and like constantly updating. The way that it was taught to me, like when I first came in, was that you should have like a running CV. Like you should have a CV where you're just updating constantly. You're putting all like your presentations, all the conferences you attended, even like disaster training, all those little unique things that you've done every year. You should just constantly update. Um, so it doesn't have to be perfect, but as long as you have that long list going, that way at when you're in fourth year, you're not trying to remember all of the stuff that you did, all the morning reports, all the presentations. When you start getting to like, fourth year, you're gonna want to tailor it to the practice. You're gonna do whether it's like community, academic, or fellowship. Um, you want to at least tailor it to what would be specific to that role. There are resources online like Emra, like you can Google uh like White Coast Investor and all that stuff. But don't forget about like your alumni and don't forget about admin and faculty. They've been around the block. They've done this. They're good people to reach out to and you should have multiple people editing it. Around like June, July for like fourth, like when you become fourth year, I think it's a good time to like have like a point of where you have your CV done. And then even though people that you're reaching out, you should consider them being your references because they're gonna review your CV, they're gonna know you, they've worked with you. That way it kind of like serves two folds, two purposes. That way they're looking at the CV and they're editing it, and they can also, prepare for a reference later on. In regards to the CV, make sure you're editing it always, checking for grammar errors. Try not to be too mundane and boring. Try to be interesting. This is the time to like sell yourself and sell why you should be employed. People like employees look through hundreds of these all the time. So like if it's just the same stuff or repetitive, it's kind of hard to like, stand out. Next is like the cover letter. I know some people went straight into a medical school. Like I had a job before, so I was a little familiar about like cover letters. Sometimes like, like employers ask for it, sometimes they don't, but it's better to be prepared. And most times, I would say like around August, you have it prepared. You should, the cover letter is pretty simple. It's basically saying, um, why the potential employer should hire you. Should you describe your skills and your experience as it pertains to the job and why you're hoping to land a job. You're gonna say like whether you're looking for a fellowship, full time, part time, want to be a part of the core faculty. You want to convey a connection. Maybe you have like strong ties to the area. You've been like for me, I was born at Kings County. Like say I was born at Kings County. Or that you love the population. There's also time to show that you know the facility pretty well. Um, their skills and experiences are a big thing. Like, yes, they're going to see your CV, but sometimes things are not in your CV yet that you haven't completed. Like maybe you're working on a new research project and you haven't had it published. That way you can at least put it in their CV so they're more aware of it. Um, it could also illustrate like, past challenges that you've overcome that, demonstrate like the strongest skills in the past. Be positive and professional. This is not the time to like, I know everyone has personality, but don't go all crazy on it. It's still formal. Be very meticulous. This is also something that someone should review, and you should have multiple people lay eyes on it and edit it as well. Um, like I said, I would try to have it done by like August, September. That way, you're not waiting to the last minute to where I work on the cover letter. But also at the same time, you shouldn't be using the same cover letter for every facility. You should adjust it as needed. You should have like a generic one, but at the same time, you should be able to, quickly make the edits and send it off to any employer. In terms of networking, that's a big part of, I think, where you're going to be able to find jobs. Uh, I know people are at court right now enjoying themselves. Not me. I had to do all these 12s. But anyways, there's conferences like ASAP is coming up in August. Um, like New York ASAP. And I believe ASAP in this year, September is in Vegas. Core next year is in like Seattle. So these are all opportunities to start networking. You'd be very surprised. Like the EM community is very small and everyone really knows everyone. Um, our faculty is pretty well known as well, so they know most people as well. So it's a good place to like reach out and start like networking, start thinking about where you want to go and jobs. There's also going to be career fairs. Sometimes the hospitals have at different medical schools. There's different organizations. Like I know like some large employers as well, they also have conferences. For me, I went to Chicago, I went to like Vegas, and they flew me out. They paid for my plane, they paid for my hotel, they paid for my food, they paid for my transportation. And then at that time, you were able to meet with the medical directors of different areas, and you could actually like, do like mini interviews during these actual like conferences and the career fairs. Also reach out to your alumni. There's a recent grads. There's a robust like alumni network. I don't think we appreciate it as much. And then you can reach out to Dr. Willis and he can get you in contact with, most places. Um, Start. It's still coming down. There's also like different like orgs that do stuff like Career MD, Practice Match. They do like career fairs in the city. There's these local like events, like other organizations like Team Health, things of all those natures that they hold. You can attend these, get the free food, but also network as well. Yeah, why is it doing this? In terms of like choosing where you want, I think it's you have to like be real with yourself. Like whether you want to do like community, academic, fellowship, maybe you don't even want to work full time, you want to work part time. But at one point at second years, third years, whatever, like you just have to realize what you're aiming for. It's never too early, it's never too late. Whether you want to do like academic, it's more like usually cutting edge, is like safety net hospitals. Unfortunately, it's a little bit lower salary, but the benefits are much better and it's a better job security. Um, the thing with it though, it's an academic position, so offer like fewer clinical hours, but sometimes you have more like teaching responsibilities. Possibly you have to be like more committed to research as well, or you could go into community where sometimes you might be expected to do everything. You might work longer hours. Some places are like rural areas. You do like 24 hours shifts, but you have fewer clinical responsibilities, and sometimes they have better salaries, but less like worse benefits, unfortunately. Or you could be in like a large urban community hospital center where they have many specialties, there's less transfers, you have similar to like what you're used to. Or like I said earlier, like a smaller community hospital where it's less backup, more less support, there's more transfers, and you could be like single coverage by yourself. Or you could think about urgent care. Urgent care, less stress. It's more like a fast track. The salaries are much less. Sometimes they get offered like ownership as a possibility. They come with benefits as well. They're more comfortable hours. It's less complex work, but you're seeing a lot more patients, a lot more than you used to. And we don't do a lot of fast track care, so it might be a little different. Um, but then there's other also opportunities like freestanding EDs. Um, in general, freestanding EDs are they're the emergent facility that's not physically connected to inpatient service. So there is no like inpatient hospital, but they're not like urgent care, but they're able to work like a standing ER by themselves. They can see most traumas, not most traumas, more illnesses. They're located more conveniently in the community, so they're easily accessible, and they're usually like 24-hour. There's usually like two types. There's like a hospital outpatient departments which are like owned and operated by like the medical centers and the hospital system. So they're like under the federal regulations, they accept Medicare and Medicaid, and they have to like abide by EMTALA. Then there's like the independent freestanding emergency centers. That's more like in other areas, that's less likely in like New York City. They're less like mandated, there's less regulations, so they're little like specific with like the insurances that they accept. So like Medicare, Medicaid sometimes is not accepted, they don't use payments and so forth. Lastly, there's like locums. You know, you can end up anywhere. I know a few of my colleagues are doing locums, but usually it's like geographic specific. So you could be in like, you know, Midwest, you could be Northeast, but within that area, you could be anywhere within that section. It's usually more helpful for like places that have like staffing shortages. So sometimes you know the shifts can be different, but because you're locums, you can at least ask for like, you know, specific times, like, oh, I want to work these dates. The rates are much better. It's most often like a 1099. Um, but there are like a lot of companies that offer it as well. And then I didn't put in more slides, but there's a lot of other opportunities that are available, like event medicine. You could work like concerts part time. I know Breville does like the MBA. There's like telehealth. There's like ketamine clinics. So like there's a vast opportunity for employment, and it doesn't always have to be like the straightforward ones that we're used to, like academic fellowships and so forth. Um, I know also when you're thinking about like what type of like place you want to work at, you also got to think about the salary when it comes to like contracts. Um, we're used to like the W-2s where it's just a typical schedule like residency, you know, your taxes and deductions are held by the hospital. You get provided health insurance, basic life insurance, sometimes most times disability insurance like 403Bs. Not all the times is PTO included, even if you're salaried. So you have to look out for that if you're concerned about that, if you want paid time off. Um, but like 1099s are independent contractors. So you're paid by the hour. It's a fixed hourly rate. It's not taxed. So you're the one that have to tag. You have to pay for everything. You have to understand tax liability. You have to have a good like financial advisor because you have to pay like most likely quarterly payments. You know you're getting your money and you're putting money aside because you know you're gonna get taxed and you have to pay. You know, got to pay the guy. You got to pay the big guys. Um, Most times you got to pay for, you know, life insurance, you know, health insurance. Sometimes they offer like disabilities and offer like matching 403Ks and 403Bs and so forth. Some I know some attendings talking to them. In other places they do like S corps and LLCs. You guys could look into that. Most times 1099, you don't get PTO. So you don't pay time off. You got to work certain hours and you have to work that, you know, no matter what. If you want to take time off, you don't get paid. But you have to come back and work more hours if that's the case. Lastly, there's like democratic groups. It's kind of like a mix of both. Traditionally, it's giving like physicians an opportunity to make decisions about like equal voting to all its members. So like if you want to, you know, if you want to do like more money, like offer more money, everything has to go to a vote. If they want to work at this certain place, if they want to change like certain rules, it's all voting. It's usually supposed to be transparent. So offers like partners opportunities to look through like financial records. Um, there's often like partnership tracks, like you can, well, if you're not a partner, you get taxed like a hospital faculty. But if you're a partner, usually like independent contractor. There's other like groups like private and corporate that I didn't talk about, but it's kind of similar as well. You can do more research. So you know what type of like place you want to go, whether it's academic, it's like community. You want a salary or 1099, but you also got to think about the location. I think location is big for me. Like I want to be happy. I feel like New York City, I can be happy, and that's why I wanted to go somewhere else. This is from ASAP. On the left-hand side, these are the most recent numbers for 2024. As you can see, those are the top 10 states for opportunity. Doesn't mean like you get paid the most. It doesn't mean anything. It's just like the most available jobs. Um, as you can see, these are the top 10 cities right here for opportunity. I'm not gonna read them out. You can read it yourself. I couldn't really find the most up-to-date like average salaries. The last one I could see was from ASAP, 2019 to 2020. These were the compensation reports. Um, the highest rate was $395 per hour in New Mexico. The lowest rate, I don't know where this was, maybe it's like urgent care, was $130 per hour in New York City. This was published in the ASAP report. Um, the report itself was averaging over 1,560 clinical hours. So that's about like 30 hours a week. If it's like you're working straight 52 hours a week. If it's less, if you take like a month off or like you have a 6 week, if you 6 week month, like 6 weeks off, it'll probably be like 36 hours a week average. Um, they were saying like sign-on bonuses could be as high as like 150,000, with the average going on to be about 40,000. And this is all over. This is just all the averages. For California, the average it was $240 an hour, with the average salary $405,000. Florida was $219 an hour, with an average of $372,000 annually. Um, New York was an average of $216 an hour, for an average of $367,000. Um, and then Texas was $250 an hour, with an average of 422,000 annually. Like these are all averages. You have to take into consideration benefits, RVUs, things of that nature, whether you're nocturnist or not. Um, so I wouldn't take, and these numbers are like 4 years old. I couldn't find anything more up to date. But that just gives you a rough estimate of like some of the numbers, some of the most common places as well. So you're trying to figure out where to look. I know this is the biggest thing for us is like we kind of got tossed to the wolves. It's like, oh, where are we gonna go look for a job? It's kind of, scary, but Willis is gonna send out you emails constantly about different academic places, but like for me, I'm not academic. I don't want to go to academic. I knew that from the beginning. I wanted to do more like community, wanted to work on my own, didn't want residence. So reached out to like recent grads. I'm in a fraternity, so I reached out to some of my frat bros, reached out to some of my friends that are doctors, but there's also alumni networks. Don't be scared. If you know a place you want to work, you speak to faculty. They might not have a friend, they might know someone, or you can reach out directly. Like I said earlier, career fairs. There's LinkedIn as well. Um, there's different organizations like Healthy Careers, Career MDs, Practice Link. There's so many stuff. But just be aware of the recruiters. They're gonna sell you a dream. Sometimes it's not even with a real organization, it's just with a specific hospital. So I would just talk to all the faculty, talk to the seniors just before you make any decisions, and don't sign anything preemptively. Um, when you get a contract, have certain people look at it, have admin. I think Yusuf looked at maybe all of our contracts. He's a good person. Um, but you gotta look at the fine print. When you venture outside of like New York, like if you go in different places, like for me, Texas, a big thing was RVUs. RVUs is more just like metrics based. It's a basic component of like the resource-based relative value system. Simply said, it's just a system used by like government programs and private insurance companies to determine how much to pay physicians for services rendered. Um, so basically, the Centers for Medicare and Medicaid and private payers, this is how they just determine like physician payment. With RVU, doctors are paid more for complex procedures and services, and they earn a premium for like working with patients requiring complicated medical care. It doesn't directly translate into physician compensation right away. Um, But under this payment, RVUs, is broken up into three things. So there's total RVUs, there's geographic practice cost indices, and there's conversion factors. In terms of RVU, it's broken up into three things as well. It's work RVUs, practice expense RVUs, and malpractice RVUs. The work RVUs make up about 50%, practice expense RVUs make up about 45%, and malpractice RVUs make up about 5%. So work RVUs is really your work. It's what you're doing when you're performing a procedure or service. You take into consideration your technical skills, your physical effort, your mental effort, judgment, and amount of time required. The practice expense is more like the cost of labor, and like operating expenses like, supplies, rent, equipment. And of course, malpractice is just malpractice. So if a service has like six total RVUs, that means the resources consumed by it is six times greater than a regular procedure with one RVU. In terms of like geographic, like practice cost indices, It's more a way of like balancing out and equating like achieving fair and equitable physician compensation around different geographies. This is also broken down into three. It's a work GPCI, practice expense GPCI, and then malpractice GPCI. I put on here just like, four random, places. There's like New York City, Arkansas, San Jose, and Wisconsin. And as you can see, like in New York, it's like malpractice is almost like triple like in Arkansas. You know, the practice expenses are much higher, and then the work is just a little bit more. Um, and then these adjustments are like updated like every 3 years by the CMS. And then lastly is conversion factor. Its simplest terms, conversion factor just converts to a value expressed in RVUs to dollars. It represents like a constant like monetary amount, and is usually applied to all services and procedures, and is adjusted every year, and is taken into calculation from the previous year. So in 2024, the conversion factor is $32.75, we'll say. So what does that all mean? Like, how does it all add up? So say I took a random like CPT code for a repair of a tendon, or not repair tendon, like a laceration repair of the arm. So you would take the work RVU times the work uh, GPCI. Then you add that to, the PE RVU with the PE GPCI plus the malpractice GPCI, and then that would come up with a payment amount. So for that CPT code for the laceration, I did it for like Arkansas because I didn't want to choose New York. I just did a random number. It came up to like 20.38. Then you will multiply that by the conversion factor, which, like I told you last, in 2024 was $32.75. So for laceration repair, we would get paid about $700. So that's how it all comes about with like RVU. I know it's a lot of math. I hate math, honestly, but I think once you start going to place with metrics, it's better to understand this now. Like RVUs affect you because of productivities. It's measured how many patients you see per hour, and the number of relative value RVUs you can generate an hour. On average, it's about like 5 to 8 an hour. It's usually, the national average of RVUs. And through all the factors that clinician can control, the one thing that we can control the most is our documentation. I know that's over the past years, they've been teaching us more about how to document, how to actually properly document so we can actually get paid for everything. And it's all about billing and coding. Um, there can be significant variability in productivity, but if you document really well for a patient with chest pain, it can equal it to up to like 3 patients that you did not document well for chest pain. And you can lose thousands of dollars, not only for yourself, but for, the facility as well. One of the common causes for like underbilling is inadequate documentation of procedures and critical care time. I think here we don't do it like a not to fault staff or anything like we don't get taught well about critical care time. I would say like the rising seniors, like third years, just take a time like when you're in CCT and just look at attendings notes. They often do like document critical care time, and you should look at the notes, see what they're documenting, see the time that they're doing, see what they're saying, just so you can be familiar with it. So when it's time for you, you have a jump start. Um, in terms of like inadequate documentation for procedures, we do like an abscess. If you look for an abscess, like an IND, a simple and complex can equate to different things. A simple IND can come up to, I believe it was like 2.77 RVUs. A complex, um, a complex IND could come up to 5.12. A simple is just, you just drain it, but most of us are doing complex INDs. We're probing by CMS guidelines. If you probe, if there's multiple abscesses or if you pack, that's a complex IND, and you're supposed to, mark that. You're supposed to get your money. That if you just put simple, you're losing in $10,000 in revenue for the department. Similarly, like if you have a laceration repair, they're usually coded by the length of the laceration. So 2.5 centimeters or less is about like 1.2 RVUs, and then higher than that is about 1.7 RVUs. Um, in regards to like crit care documentation as well, it's not always every patient is CCT. So if a patient's put on BiPAP, you can document for crit care time as well. So CMS defines like crit care time as any patient with a high probability of like imminent or life-threatening deterioration or illness that impairs one or more vital organ systems, or someone that requires frequent personal assessment or manipulation as well. So I would just, once you get to third year, fourth year, you're figuring out where you want to go. If you feel like like for me, I know I'm doing a lot of metrics basis. So it's just starting to think about that. Start thinking about your documentation, start diagnosing appropriately and admitting for the appropriate diagnoses. But what's the difference between like RVU and salary compensations? It's basically comparing like commission versus non-commission service providers. In a salary model, you're not that stressed. There's not that much incentive to work faster and treat as many patients as possible. But like if you're working with RVUs, the organization, the facility you're working with, they should be very efficient. You want to see as many people as possible because you're also making more money, but it could be a little bit more stressful. Um, but in terms of, I made a little comparison. These are actual contracts I got. I'm not gonna tell you from where, just so you know. Job one, it was a W-2 base. Annual salary was 290,000. There was 4 weeks paid PTO, 9 holidays, 1 week CME. So in total, that's like about 6.5 weeks of PTO. The 1,630 annual hours was after the PTO time. So that comes up to about like I think 36 hours. I did a Yeah, 36 hours a week basically is what they wanted to work. Job two was also W2, but it was RVU based. The base salary was 156 hours, $156 an hour, which came up to about like $225,000 roughly. But they were also paying you $15 per RVU. So saying you're seeing like 6 to 8 RVUs per hour, we're gonna say six. That's like extra $90 an hour. So the salary came up to 350,000. There's no paid PTO. There was 1,440 annual hours. Okay, but you're not getting any PTO, so you're working about like 30 hours a week. Um, this is very simplified because you have to take in consideration the benefits. For now, I'm just saying the benefits are similar, but when you take into the benefits like health insurance, disability, malpractice, and then also like 401k and match, these salaries can be almost as similar, even though you feel like you're getting paid less, but the benefits are much better. So it's all dependent on what you want and the type of place you want to go, type of place you want to live. For me, I wanted to get out of here. I wanted somewhere else different, and I wanted to try while I'm young and healthy, something with like RVUs and see, how that would go with me. And in closing, I think like we psych ourselves up a lot. Kobe, I love Kobe, almost as much as MJ. But like he said, we psych ourselves up too much. Like if you try to talk yourself into, oh, this is a big moment, this is a big shot, you're putting a lot of pressure on yourself. You shot the shot 100,000 times to shoot another one. We've done medical school, we've did interviews, we've done the CVs, we've done residency. Like it's the same thing. Honestly, I could talk about interviews. It's the same thing. Once you go through one interview, it's all the same. Once you do your CV, it's pretty much the same. Just take your shot. This is time. The worst thing that can happen is that someone says no. In regards to contracts, like I said, get admin. Yusuf is very good. He's like very down to earth, and he'll tell you if the contract is trash or not. Um, don't worry about interviews. Like you get the questions, you get the flow of it. They'll all be the same. Don't try and just get the job with the best sign-on bonuses because it usually comes with a catch. And usually it's like it's attached to like a 1 or 2 year commitment, and if you leave the company early, you gotta pay them back. And then for like all the like rising fourth years, don't think like everything's gonna be vacations. You gotta save money. Licensing and all these miscellaneous fees are a lot, and you should start early. So for like New York, it could take up to like 3 months. You gotta pay $735, and there's like miscellaneous fees as well. For Texas, it could take up to like 2 months. You're paying $800 with a registration fee, so that's another $470. California, I feel sorry for y'all. It takes up to 6 months. Um, you have initial fee of like $600 with a registration fee of like another $600. And then there's like all this other miscellaneous fees that no one tells you about until your fourth year and you start paying for everything. So like the Federal Credentials Verification Service, I don't know if you guys remember, it's basically where they you send them their transcript. Is the one that they have like all your step one scores, step two scores. You gotta pay them more money again so they can send it to the board. Or you can do it yourself, but it's kind of easier. I just elected to do it, have them do it. So they just collect all my information and just send it off to the board itself. You gotta pay for fingerprinting. DEA licensing is another like $800. Um, ATLS, I'm sorry, even CIR people, it's not covered. That's another. All I saw the cheapest was like $600, $750 as well. ACLS, PALS, and stuff like that, CIR people were covered for that if you do it early enough. Downstate, I'm not sure. You could talk to, some other downstate people, but that's on you guys. Um, then there's also, you gotta think about the cost of like your boards. You don't have to pay it right now, but that's towards the end of residency. You gotta pay to register. So you gotta pay a $400 fee to register. Then you gotta pay another $960 just for the written boards. I know the rising third years or fourth years now soon. The oral boards are different. You're gonna have to be, I think you have to go to North Carolina. You're gonna have to talk to Hassel about that. But then there's also moving costs and all these other miscellaneous fees. So don't waste all your money early. You know, think about all these things and start planning accordingly, especially in your third year, because I travel a lot and then these fees really ate up my bank account. So I just wanted to open you guys up a little bit more about like fourth year and like job wise and things of that nature.